Yeah. So I think long case is important. Single long case of 100 marks, and you have 50% or more chances to get a hip case, and 50 would be a spine case. So these are, you know, if you really think of all possible long cases that you can have, they are fixed around 10 or long cases. I will go briefly, I will not, so that we can have more time for the actual, I hope somebody has already taken this. Has anybody taken, or you are going to take now? You are already taken, that's natural. So these are the fixed set of long cases in hip. Now you can have AVN, you can have tuberculous hip, you can have ankylosing spondylitis, perhaps rheumatoid, you can have non-Indian PC or IT, malunited, rarely malunited, this thing, rarely post-traumatic, something like acetabular fracture, post-traumatic arthritis, and sometimes, of course, a child congenital dislocation of it. These are on a rarer side because they are treated now very picked up and treated very early. I can tell my MS experience, which was way back, almost 35 years back. I had a case of congenital dislocated hip, which was untreated in a 5-year-old. But I think now, this era, I think this would not be very common, yeah, because they are picked up very early. But so these are, and ankylosing spondylitis, which has multisystem, as we had just discussed it some time back. They have spine involvement and hip, and then you have to present both. And what is tricky about this is you have combination of this, the deformities. You have to, one side adduction deformity, other side abduction deformity, combination of this, and then you have to do these various tests, whether you are able to square the pelvis, how do you measure the limb length. This is something tricky, and more you practice, I think more conversion you would do. So I think without So I will go. You know the general principles. You always instruct the patient as to what you are going to do. Expose the region properly to be examined. Keep a loincloth there and keep the ribs, not just the shorts there, so that you can mark. Okay. Compare both the limbs, active, passive range. Examine the joint above, below. Do not forget the lymph nodes, which is always after describing everything you forget the lymph node drainage area, that you don't do that and do not cause pain. So history taking, I will go briefly on that. History taking, ODP, onset, duration and progression, pain. So pain, you see what examiner wants you to do is, many times, which is may not be logical enough, but they want you to come to a diagnosis at the end of the history. Many times they would ask you, what is your impression? So basically, what they are trying to see is, after eliciting all the history in detail, you create a clear picture, so that examiners also have a clear picture as to what is your thinking process, what are you thinking in terms of, So location, of course, we are talking about hip, so location, radiation, how did it start, the contributing history. As I told you, AVN is a common race. So history of basically steroids or weight gain, or now in this present era, COVID infection, that is also a cause because of the COVID itself, or steroids being given for during the course of COVID. Patient had a ICU admission, and during the period long term steroid injection. Many take it for bronchial asthma or skin lesions, or young patients take it for bodybuilding. So these are common. It will just add some few points that you have adequate knowledge. You are trying to elicit the history of long-term steroid intake in this patient. History of alcohol, the amount of alcohol and years of alcohol that patient needs to take before. It's like how much amount of alcohol would it be necessary to develop a fatty liver? The same amount would cause mastocytosis and hip, and would cause AVN. So we will not go into the theory, but you can try and elicit the history. How is the progression? When is the pain? Say you have typical ankylosing spondylitis, so eliciting history of morning stiffness which is lasting more than half an hour. As they go along, the pain of stiffness decreases. So this is something important. If you are thinking in terms of rheumatoid, exacerbations and remissions, barometer joints, something of that sort. If it is a mechanical in origin, then pain increases after the activity. And what is the any hip case, the examiner expects you to know what is the functional disability. So activities of daily life. So in the Indian style, we need a lot of squatting and sitting cross-legged. So squatting will involve flexion more than 90 or 110 degrees. Squatting, the sitting cross-legged will involve flexion, abduction, and extension. He has to sit in this position, right? So whether he is able to do it, how much is the pain, whether he requires NSAIDs on a regular basis, okay, whether he requires narcotic analysis in a form of on a daily basis, does he lose his daily wages because of the pain? Is he employed, gainfully employed, or is because of this pain? So go into micro details, and that is how you would present. So pain is the important factor. Then is he using any walking aids, stick, or is he able to ambulate? Has he noticed any limb or shortening? He has noticed. He may have noticed. So take that history. Whether any walking aids are being used, stick, crutches, walker. Okay. How much is the ambulatory capacity? How much? Whether it is a household ambulator or community ambulator. So take the history taking. As I told you, you take so much history that at the end it creates a clear picture in front of our mind that what this could be a possible. So you narrow down your diagnosis. What are you thinking in terms of? And we know the back side of our mind. There are fixed things, fixed diagnosis which you are going to get. There are 5 to 10 cases, fixed long cases, and you make a format, whichever. So the presentation, sometimes I will tell you an example. If you would like to describe the gait in the beginning, if you would like to describe so you have that fixed format for you, whether you would like to describe the gait at the end or so. So have your format, write it down, right? This hip case, take this case for example, write it down, and then you just have to fill in the blanks. For every case it will be different. So your format is ready. Many times what happens is examiner stops you. Examiners want to examine. Examiner asks you to demonstrate the test. Then you may lose your link of your. So you should not lose your link of that flow of presentation. For that, your format should be ready, fixed, and you follow that. So wherever you are paused, again when you are asked to start again, you are starting at the point where you had left. So you don't. Sometimes it may happen that you may be in that thing. You may miss out few things, and which is not accepted. At the end, the exam said you did not mention this because the link was broken. So the usual tendency of the examiners, as long as you are going smoothly, they won't interrupt you. They may ask you to demonstrate few tests. Usually they won't interrupt you. But if they find there is some discrepancy in the, say for example, there is a abduction deformity, and then you are coming with the you are saying that there is a limb that is shortening, then something antennas rising. The examiners want to check. You are saying abduction deformity, and then you are saying there is a shortening. It is possible because the cartilage loss, but then you should be able to. I am not trying to suggest that you manipulate, but your history taking, your examination findings should correlate. There should not be any discrepancy. Whenever there is a discrepancy, examiners are mature enough and smart enough to pick up on that, and then they will tell you, you demonstrate this test, show me, how is it? So back to our, just go in detail about the pain, then medications that he is taking, stiffness, limb, whether he has noticed, limb length discrepancy, whether he has noticed, okay, and whether any difficulty. Snapping and clicking, snapping hip is not a long test, don't bother about that, but you may. So attitude, inspection, coming to the inspection, here examiners, you don't have to say that I would feel that this is my provisional diagnosis. You have not made any diagnosis, you don't have to comment unless examiners ask you what are you thinking in terms of. So there you can say, based on the history, I would think, I am thinking in terms of these things, whatever, 1, 2, whatever. I hope you know the difference between attitude and deformity. Do you? What is the difference between attitude and deformity? Anybody? What is attitude? Not what students show. So what you see is the attitude. What cannot be corrected, that is just a lie of the patient. What is on the inspection? But what is fixed, what is good, the one which is not corrected is deformity. So on inspection you will comment on the attitude, not on the deformity, right? So you see overall, you expose the patient properly, see the muscle vestings from front, gluteal muscle, unless you make the patient prone or stand, you will not observe that gluteal vesting, scars, spinal deformity. See from the front, side and the back, and again you see the deformity. Level of the anterior superior iliac spines of the patellae, both the malleoli, lie of the limb, whether patella usually would be around 10 to 15 degrees external rotated. Okay, so if it is excessively rotated, then you may think of, say, it can be non-union IT or TC, where there is a external rotation. You have typically, there is nothing in the rule, as you saw, tumor is there is no rule in the tumor. But similarly, usually, I forgot to tell you, Perthes is Perthes in various stages can be an example, long case. So it can be in a stage of transient synovitis, it can be stage in the early stage, or it can be late deformed. So usually in Perthes or slip capital epiphysis or AVN, there are two things which are restricted: abduction and internal rotation. These are the things which are restricted. Okay, so you should keep in mind. Whereas we have those classical 3 stages, stage of apparent lengthening, stage of apparent shortening, and true shortening, which every time it may not follow. Anybody knows about these 3 stages? Apparent lengthening, when does it happen? Stage of synovitis, that's nice. So what is the deformity, typical deformity? Internal rotation, external rotation. Because it is, why is that so? Why